Good afternoon, one and all. This is about a child who had like various manifestations of tuberculosis. To start with, this is about a 16-year-old boy who was symptomatic since May 2020 with complaints of intermittent fever, pain, abdomen, diarrhea, and weight loss persisting for 8 months. And he also had perennial purulent discharge for lasting for 1 month. With these complaints, he was initially admitted to Child Trust Hospital in the month of. So one second, the screen is. With these complaints, he was initially admitted in Child Trust Hospital in the month of December 2020, and he was diagnosed to have Crohn's disease based on his clinical presentation, his endoscopic findings, his biopsy findings, and his radiological findings. And he was started on steroids after a TB screen was found to be negative. And the TB screen included a chest X-ray, IGRA, and his gene expert in the ileal biopsy was negative as well at that time. On this treatment, like he was apparently doing well, and he was started on tapering dose of steroids, and he was started on oral azathioprine in the month of Jan 2021. He was fairly doing well on this, but in the month of April 2021, he had a flare up of the disease in form of increased perennial purulent discharge with recurrence of fever spikes and increasing ESR. So he was started on biologicals with infliximab. He was apparently doing well following this, but in the month of June, he again started to have recurrence of loss of weight and loss of appetite with cough and expectoration and recurrence of fever, which lasted for 1 month. So he was admitted again in July 2021 in Child Trust Hospital. At the outset, I would like to give an overview of all the issues he had during the hospital stay. And in the upcoming slides, I'll be explaining 3 major challenges that we faced in managing this child. So at admission, he was found to have massive right pleural effusion. He was started on empirical antibiotics, and an ICDT was inserted because of respiratory distress despite therapeutic TAP. His etiological workup of right pleural effusion showed a positive gene expert in his sputum, which was rifampicin sensitive. So for his pulmonary tuberculosis, he was started on ATT. He also had pancytopenia at admission, which was probably attributed to the azathioprine drug-induced pancytopenia, and he was started on filgrastim injection as per the hematologist opinion. He was also in the later by the end of first week of hospital stay, he was found to have SVT, for which initially he was started on oral ivabradine. He also required infusion of amiodarone. After controlling the rate with this, he was started on oral amiodarone and oral carvedilol. At the same time, he was also found to have left ventricular dysfunction, which required diuretics initially, and he had a worsening at around the mid of second week of hospital stay, requiring a brief period of 24 to 48 hours of inotropic support with low-dose milrinone and low-dose adrenaline, and also CPAP. He also developed Stridor at the same time in the mid of second week of hospital stay, for which he was treated with adrenaline nebulization, IV dexamethasone in airway doses, and CPAP for 24 to 48 hours. He had recurrence of fever spikes at around the same time in the mid of second week of hospital stay. Possibility of sepsis was gram-negative septicemia was considered, and in the background of pancytopenia and hemodynamic dysfunction, he was empirically started on meropenem and colistin, and his blood culture grew Enterobacter sepsis. With the above antibiotics, his fever spikes settled, and he also developed AKI in the second week of hospital stay, which was again multifactorial, but it improved with supportive therapy. So while managing this child, the major challenges that we faced were in the identification and understanding and the treatment part of supraventricular tachycardia, cardiac dysfunction, and Stridor. So I'll be discussing one by one. To start with, the SVT. Sir, excuse me, my slide is fully visible, or is it being
fine, proceed.
Visible, sir? Okay. So, he had persistent tachycardia since not persistent. He had intermittent episodes of tachycardia since admission. A detailed evaluation of his rhythm strip showed a heart rate of 188 per minute. His P waves were inconsistent and had a variable morphology. As we can see, the P waves are present in few of the leads. In few, there were a negative deflection, and in few, it was not detectable, and in few, think it was following the QRS complex. So he had an inconsistent P wave with variable morphology. So his PR interval again was indeterminable. and he had a constant RR interval with 0.32 seconds, and the QRS complex was narrow with a value of 0.08 second. And this pattern was persistent throughout his rhythm strip. So with these findings, a diagnosis of supraventricular tachycardia was made. And as advised by cardiologist, he was given a start dose of IV adenosine rapid bolus. But despite his adenosine rapid bolus, we can see his supraventricular tachycardia recurring at this point with pleomorphic T waves again. So like possibility of atrial ectopic tachycardia was considered. He was initially started on oral ivabradine, which is a oral antiarrhythmic drug. The advantage of this drug is this doesn't have negative inotropic effect. So in the background of cardiac dysfunction, cardiologists chose to start oral ivabradine. He initially had a brief response to oral ivabradine. His rates came down, but he had recurrence of SVT, so he was started on IV amiodarone infusion. With these two above management, he had his rhythm changed to sinus, but he had persistence of tachycardia. His heart rates were lingering around 130 to 150 per minute. And at this point, there was no explanation for this persistent tachycardia. There was no worsening of cardiac dysfunction. There was no hyper or hypovolemia, and there was no worsening of sepsis. There was no fever or no pain. So at this point, when the clinical picture was not very clear, we considered possibility of drug interaction. And when we reviewed the literature, it was found that ivabradine, which is metabolized by CYP3A4, when used in combination with CYP3A4 inducers like rifampicin, the value in the serum decreases markedly, and such combinations should be avoided. So following this, we also checked the interaction of rifampicin with other oral antiarrhythmics like carvedilol and amiodarone. Though a similar interaction is also found with amiodarone and carvedilol, the serum level is decreased, but it has been recommended that we can continue the therapy with these drugs, and we can monitor the therapy with these drugs. So based on this review, we stopped the ivabradine for him, and we continued oral amiodarone, and we added on oral carvedilol for this child. With this management, his heart rate came down to 90 to 100 per minute, and his rhythm changed to sinus rhythm. At the start of SVT, when his diagnosis was made, we looked for other treatable causes. His potassium was normal, his sinus calcium was again normal, his magnesium was normal. He had a massive pleural effusion, which, as I mentioned already, we placed an intracostal drainage tube, despite which his SVT was persistent. In the absence of underlying congenital heart disease, we did not have an explanation for his SVT. So possibility of myocarditis was considered as well. The next major challenge we had was in understanding this cardiac dysfunction and managing this cardiac dysfunction. So this child had clinical features of a cardiac dysfunction in the form of history of orthopnea. There was tachyarrhythmia with gallop rhythm, which the gallop rhythm set in after a fluid bolus was given, and he had bilateral crepitation with mild hepatomegaly. However, there was no elevated jugular venous pulse or dependent edema. His echo was showing a poor ejection fraction of 40%, and he had moderate to severe LV dysfunction. Though his pericardium was prominent in the echo, there were no features of constricted pericarditis, and there were no features of pulmonary arterial hypertension. This is the video of his echo, which is showing pretty fast heart rate with poor contractility. With this cardiac dysfunction, we consider the following differential diagnosis for him for his cardiac dysfunction. The first differential diagnosis we considered was could it be tachycardia-induced cardiomyopathy? The second, tuberculous constrictive pericarditis. The third being tuberculous myocarditis. The next differentials were like ATT-induced hypersensitivity myocarditis based on a few case reports, or could it be sepsis-induced cardiac dysfunction worsening the clinical picture, or a rare possibility of even extra-intestinal cardiac manifestations of Crohn's disease was considered. However, since there was no clinical worsening of Crohn's disease, the possibility of extraintestinal manifestation of Crohn's disease was ruled out, and his cardiac dysfunction persisted to be there even after controlling his sepsis. Hence, sepsis-induced cardiac dysfunction was again ruled out. And for the possibility of ATT-induced hypersensitivity, we transiently stopped this ATT for a couple of days and reintroduced it. Despite reintroduction, there was no worsening of his cardiac dysfunction. And again, his serum Ig level was normal. So hence, this possibility of ATT-induced hypersensitivity myocarditis again was ruled out. And he did not have any clinical and echo features of constrictive pericarditis. So TB constrictive pericarditis again was ruled out. Again, there was no significant improvement in the cardiac function even after controlling his heart rate. But with this fact, we were not able to rule out his tachycardiomyopathy. So with the finalized narrow differentials of tachycardiomyopathy and TB myocarditis, we reviewed the literature of TB myocarditis. Like TB myocarditis as such, the incidence is very rare. The mortality is very high. Many a times it is diagnosed post-mortem. And out of all the reported articles, all the patients, isolated TB myocarditis has been found in 25%, and TB myocarditis with concomitant other organ involvement has been reported in 75% of the reported cases. The exact mechanism of TB myocarditis is not very clear. Three mechanisms has been postulated, and they are like either hematogenous seeding or the direct seeding from the infected pericardium, or a retrograde lymphatic drainage from the tuberculous mediastinal lymph node. And three different types of TB myocarditis has been explained in literature. One is diffuse infiltrative form, the second is caseating nodular form, the third is miliary form. And the clinical presentations can vary from acute myocarditis with congestive heart failure features to arrhythmia with both SVT and VT given reported in literature. Dilated cardiomyopathy, even sudden cardiac death has been reported in literature. The diagnosis is based on one of the three following tests. Either endomyocardial biopsy showing the acid-fast bacilli can be done, but few articles have mentioned this is neither sensitive nor diagnostic. Cardiac MRI can have certain characteristic features, or just a reversibility of cardiac function to normal post ATT per se has been taken as one of the diagnostic criteria for TB myocarditis. The treatment of TB myocarditis is ATT with steroids and supportive therapy for congestive heart failure, and the recovery time is usually 2 to 3 months. So with this reviewed literature, we analyzed the index child. Our child had moderate to severe LV dysfunction in the echo, NT-proBNP and TROP-I were elevated, and the cardiac MRI showed diffuse myocardial edema of the left ventricle, suggestive of acute myocarditis. A possibility of diffuse form of tuberculous myocarditis was considered. And in view of the hemodynamic instability, endomyocardial biopsy was deferred in the index child. The index child was treated with ATT. He was started on prednisolone at 2 milligram per kilogram, and which was continued for four weeks, and followed that we tapered the dose. We started him on diuretics for his congestive heart failure part, and because of poor LV function, we started him on aspirin at antiplatelet dose. With this management, at discharge, his heart rate was close to 90 to 100 per minute. The rhythm was sinus. There was no gallop rhythm, no orthopnea, and his ejection fraction has improved to 50%. The next major thing which we were not able to understand in this child was the stridor. This child had stridor at around the mid of second week of hospital stay. He had history of voice change 2 to 3 weeks prior to hospitalization. He has hoarseness of his voice. And on one fine day, he had stridor with respiratory distress and desaturation. His stridor was biphasic. With differential diagnosis of extrinsic versus intrinsic airway obstruction, we started him on adrenaline nebulization empirically, and he responded well to adrenaline nebulization. And simultaneously, we also got an ultrasound done, which did not show any evidence of cervical.
Priya, try to make it short, Priya.
Yes, ma'am. Only one more slide. There was no evidence of any cervical nodes compressing the trachea, and his X-ray at that point showed a doubtful intraluminal narrowing of the tracheal lumen. So possibility of laryngeal tuberculosis was kept, and he was continued on airway doses of dexamethasone, CPAP, and anti-tuberculous therapy was continued. With this, his stridor settled in few days, and his voice improved over a period of 1 to 2 weeks. His airway was evaluated after 2 weeks of initiation of ATT, which showed thickened right vocal cord with a scar. There were no active TB lesions at that time. However, the possibility of healed TB lesions couldn't be ruled out. So in the index child, a final diagnosis of Crohn's disease with pancytopenia, which was probably drug-induced, with pulmonary tuberculosis and right pleural effusion, with supraventricular tachycardia, with LV dysfunction, probably because of the TB myocarditis, with laryngeal TB, query-laryngeal TB, Enterobacter sepsis, and AKA was a final diagnosis made in the index child. So the take home message that I would like to give to the audience is any heart rate of more than 100 in adolescence should be taken very cautiously. The ECG should be interpreted meticulously, not to miss SVT. Drug interactions should always be considered whenever we are not seeing the expected treatment response to any drug. And reviewing the literature in rare presentations of common diseases was very important in the clinical management. Thank you.